Hello, dear colleagues. It's Conversations About Hearing. My name is Gaziz Tufatulin. Auditory neuropathy spectrum disorder probably is the most challenging topic in the modern audiology, and previously we discussed diagnostics of ANSD in children with Maria Lalayans, and today we will have focus about management of ANSD, preferably in children. And I have a big pleasure to introduce my today's guest. It's Dalia Hassan from Egypt. Dalia is professor of audiovestibular medicine, Faculty of Medicine, ENT Department, Audiology Unit. Dr. Dalia received all her medical education from Faculty of Medicine, Ain Shams University, one of the great and ancient universities in the Middle East. The doctoral degree in audiology was a joint project with the Hereditary Hearing Loss Lab, University of Antwerp, Belgium. The project studied the connexin 26 whole gene mutations in Egypt in 2002. She received an award grant from the European Commission in 2004 related to neonatal hearing screening projects. The main practice is in the field of pediatric audiovestibular medicine, rehabilitation of audiovestibular disorders, including central auditory processing disorders and genetic hearing loss. Contributor in the National Hearing Screening Program in Egypt and in development of Arabic program of remediation of central auditory processing disorders. Her professional clinical experience spread to private hospitals in Cairo and in Arab countries such as Saudi Arabia. Being a university staff, he supervises a large number of theses and is one of the members in the teaching and examiner board for the postgraduate students in audiology in Egypt. She contributed and actively participated in many congresses, workshops, and seminars worldwide. She has many scientific publications related to different audiovestibular issues. Reviewer for the International Journal of Pediatric Otorhinolaryngology and Egyptian Journal of Ear, Nose, and Throat. Dr. Dalia is a member in the International Association of Physicians in Audiology and Egyptian Audiovestibular Medicine Association. So, Dalia, good evening.
Good evening, Aziz. How are you?
I'm fine, thank you. Thank you for accepting my invitation. And
you hear me?
Yeah, I hear you well.
I'm very happy to join you, and it's my pleasure to be with you in your channel.
Thank you. And my first question is traditional for my foreign guests. Please tell us a few words about the audiology services in Egypt.
Yeah, actually, audiology in Egypt have been started since 1973. And the founder of of audiology in Egypt was at my institute, Ain Shams University. It was the first institute studying and incorporating the audiology science and audiovestibular medicine science at that time by Professor Salah Soliman. And since that time, many candidates, many students took their master's degree at the university, and then they spread all over the Egypt. Even Egypt's around 27 districts or 28 districts, and from this place, from the Ain Shams, all the students got their degree and distributed the knowledge, and each of them have built the audiology clinic and audiology unit in their institute and in their university. So approximately nearly most of the districts, except for very few, has no audiological services. This on the university level. We have many work with insurance level, so the orientation of hearing loss and hearing problems in children, even in adults, is increasing. And of course, the management. We know that we are a developing countries, so our main problem is located and is confined to the management. How we are going to manage the children, how we are going to help them financially to get their hearing aids, their cochlear implants, and to have a normal life like their normal peers. So actually, being an Arab countries and Middle East country, Egypt was the founder of the audiology in the Middle East, distributed it to the other Middle East area, other Arab countries, some of the African countries, and now we are making very good work all over. And now we are reaching you and see what you are going to do and what you are doing in Russia also.
Thanks. So let's move to ANSD topic. Is early detection and intervention in children with ANSD as important as in children with other types of congenital hearing loss? How to differentiate the permanent hearing loss caused by ANSD in premature children from an immaturity of auditory pathways?
Yeah, you have mentioned a very important point in your words. You have mentioned prematurity. So this means that there is a high risk factor. So the alarming sign or the alarming point in history taking in such a child, high risk. All the high risk register related to the neonates are alarming signs for getting auditory neuropathy spectrum disorder. We know that auditory neuropathy spectrum disorder is a lesion that affects starting from the inner ears and higher at different sites. So we are expecting to have cochlear microphonics, we are expecting to have autoacoustic emissions dependent that the middle ear is normal, and the other all higher test ABR and etc. will be affected. So if we have this, it's equal with 99.9%, it's an auditory neuropathy spectrum disorder. How we can differentiate from prematurity? Prematurity, by time, they will get the response in the auditory nerve and the ABR and all the other pathway. But actually, auditory neuropathy, it's stationary, even it may be progressive. Very rare of the neuropathic patients that they can improve. And if they improve, it's not a neuropathy because they will develop language and all the normal pathway after that. Okay.
In infants with sensorineural hearing loss, we usually base on electrophysiological thresholds to obtain a degree of hearing loss and as the start point for hearing aid fitting. But as we know, they are useless in children with auditory neuropathy spectrum disorders. So how to be? Which methods do we have?
What do you mean by useless? Useless, the tests are useless or the fitting are useless? I didn't get your point, please.
They use this to obtain thresholds to start fitting hearing aids.
Yeah, it depends on the age. If it's a neonate, so you will depend on the thresholds on doing the autoacoustic emission, distortion product autoacoustic emission. We know that the transient, the hearing, if you have transient evoked emission, so the hearing is better than 30 dB. And if you have distortion product autoacoustic emission, the hearing is better than 60 dB. So in this 60 and above, better, you can define by the distortion autoacoustic emission. By the ABR, as we know, click ABR, tone burst ABR, they do not have synchronization, so no ABR is present. In this group, it should be, and we should do sound field testing, behavioral testing, to see the response of the child to sounds. Actually, a large percent of those children, we can get a response. We can get a thresholds. We can get across the 500, 1,000, 2,000, and 4,000. This is behaviorally. So it's very important, and it's individualized process that we combine the behavioral thresholds together with the electrophysiological thresholds. Another way, presence of cortical evoked auditory potential, the P1K, is very important landmark in those neuropathic patients. If we have a child with auditory neuropathy and we do the CAPE and we have a P1 which is very evident, it's a very good prognosis. But if we have another child which is suspected to be neuropathy and we can get the P1 at a delayed latency and lower amplitude, it's a poor prognosis. This means that the synchronization effect of the neuropathy is catastrophic here in these children. Otherwise, or on the contrary, if we can get a P1 in a good way.
Did I understand?
I hope that I answered your question.
Yeah. Did I understand you right that in cases of ANSD in infants or during the first year of life, we can approximately determine thresholds based on transient evoked autoacoustic emissions and distortion product?
Yeah, and combined with it, if you can do behavioral testing, sound field testing, or visual reinforcement audiometry, it's very important in this group of children, particularly if you can get a response, and particularly if they are not of the severe and the profound degree. You know that the neuropathy, you can find any degree, mild, moderate, moderately severe. In this category, you can get by the behavioral, and it can guide the planning and the management plan in those children.
Professor Dalia, there are at least two types of auditory neuropathy spectrum disorders, which we can differentiate based on electrocochleography, but it's difficult to be performed in children. Does it really matter which form of ANSD a child has? How to figure out?
Actually, I figure out by other tests. I cannot use ECOG in those children. So I do behavioral testing. I do cortical auditory evoked potential, which is very important. And if you start to see, even in literature, and we make a few papers on the cortical P1 in auditory neuropathy, the child who had P1 at near normal latency and at proper amplitude versus another child which has a delayed latency and lower amplitude, the prognosis is different. So we can depend on other things. Importantly, also the acquisition of language after amplification. If they trying to get babbling sounds, trying to imitate sounds, try to utter words, this means that this is a type which is a good type of good prognosis type. Mostly it will be a presynaptic, not postsynaptic type. So the outcome here is diagnostic in this group of children.
Today we will talk about management strategies. Probably they different depending on the situation. So let's discuss each situation step by step. The first one, confirm bilateral ANSD with normal behavioral thresholds. What would you recommend?
Bilateral ANSD with normal behavioral thresholds?
Bilaterally, yes.
Yeah, what's the problem? At first, I'm the one that I want to ask you the age of the child first, and what's the problem? The problem with the parents, yani why they seek advice? Why they seek advice for this?
Let it be referred children after neonatal intensive care unit with risk factors to the follow-up to the audiology unit. He has OAE, but during ABR testing, he has no ABR waves. So probably ANSD. We can exclude immaturity, but we waited, for example, to until 1 year, but ABR still absent. So this child has good reactions to the near normal sounds. So is there a problem? Do you have some recommendations for the parents?
Yes, it's very good case. Very good, and already we can see it in a quite percent of patients that they have normal behavioral, electrophysiologically is abnormal with high risk register, as you have mentioned. So these children, we will follow up them on the language, on the level of language development. Is it developed properly or no? And number two, we are going to try the problem of the auditory neuropathy problem in understanding a noisy situation. So we have to improve the signal to noise ratio for them. So we can look for the possibility of using assistive listening devices for them. And currently, many companies have been giving the FM system in spite of normal hearing, either on a REC hearing aid or even an earpod. So it's very good. This solution, before we cannot find this. So this is a good solution. So language development and follow-up, starting to give them assisted listening devices, regular follow-up, and the regular follow-up for this group of children, sometimes I see the patient every month. I cannot wait for 3 months or 6 months. No, it's monthly follow-up, or even by chatting to see what's going on with this child. And importantly, to give instruction to the parents and particularly the mother, and even those who give them phoniatric therapy, what we say clear speech method in training and in dealing and in communication. I mean by clear speech that to decrease the rate of speech, to improve the pronunciation of the vowels versus the consonants, so that all the problems, we know that the neuropathy has problem in rate of speech and the temporal processing. So we are going to avoiding this and to improve this by giving clear speech way of therapy beside the language follow-up audiologically, and trying to give them assistive listening devices.
So the second situation, bilateral ANSD, elevated behavioral thresholds from mild to moderately severe degree. What's the strategy?
Bilateral, huh?
Bilateral again, yes.
Bilateral. First of all, and I insist on this point in the neuropathy, the binaural cues. So they should be fitted binaurally with hearing aids. The degree of hearing loss up to moderately severe fitting with binaural hearing aids. And this binaural hearing aids with highest and latest technology in the form of high signal processing. So why high technology of signal processing? Because as the signal processing is of latest technology, the signals will be heard very properly, noise suppression will be present in the circuit, and speech enhancement also will be present. And very important to avoid compression, avoiding using compression in the signal, because if you compress the signal, you are going to make distortion of the speech going to the child, so he is not going to understand what you are saying to him. Okay, and very important also that to follow up this child, as I've mentioned in the early of my talk, using a outcome measure in the form of subjective impression of the parents, using questionnaires for the parents, and the questionnaire about the development, about of the language, about the sound detection, sound discrimination, and speech discrimination, and finally using audiologically we can use P1 CAPE. And not recently, 2 years ago, I've made speech ABR. Speech ABR for those neuropathic patients after using hearing aids or cochlear implant. Interestingly, some around 50% of auditory neuropathy patients with cochlear implant or hearing aids, we can get speech ABR. So this means that they can synchronize, or the device can synchronize the impulses directed or present to their ears. You know that when I face a child with bilateral and moderate, like the case you have present, I become very happy, because I know that inshallah things will go better. This is a good prognosis, one of the children of good prognosis. And it's apparent even when you are testing behaviorally as a child, the direction of looking to the sound, you feel that this child you will get a response after being fitted.
You mentioned that we should avoid compression. Did you mean amplitude compression or frequency compression?
Amplitude compression and even frequency compression. For continuation to my words, that for this child, you mentioned bilateral moderate or moderate to severe. Follow up for them is very important. Again, I say, because if they go to progression and progressive hearing loss, we may leave the hearing aids and get cochlear implants. Answering your question about the compression, mainly the amplitude compression, because if you compress amplitude wise, you are cutting the peaks of the speech, you are distorting the speech going to them. For the frequency problem in the low frequency, so you should be very cautious in using the compression with such a group. Actually, I deactivate the compression circuit when I'm fitting a neuropathy patient, and unfortunately, I can get some of the children with probably very poor prognosis. When I look to the software and the hearing aid fitting, I can see that even they are using, the nonlinear frequency compression, the frequency shifting, the type of frequency compression to either to avoid the dead regions. This is catastrophic for this group of children.
So linear amplification is better.
Yeah, of course, linear amplification is better. Linear or semi-linear.
Okay. So, do you prefer increase gain gradually in the first step of amplification, or you just fit to target at the first follow-up?
No, I start to use before in last years we use very low gain. The concept to use low gain in order, because the hearing aid is not going to amplify, not going to benefit the child. But actually, by experience, by work, by scientific research, we find no, you give the gain, full on gain, but not from the start. You start two step below the full on gain, and you follow up 2 weeks, 1 month, 3 months, and you increase, but with very close follow up, very close monitoring. Once the parents say that the child is removing her hearing aids, or even you see on follow-up the child that the sound is making her grimacing, she isn't crying. I saw children, when I increase the level of sound, they are crying because this is painful for them. So actually, the full-on gain, 2 steps below, and you increase if it's proper and with no adverse effects or no complaints for the parents and the children, and you go on.
Okay. The next situation, severe or profound bilateral gain ANSD. What we must take into account considering about cochlear implantation in cases of ANSD.
For cochlear implantation, trying as much as we can to know which type. It's presynaptic or postsynaptic for the counseling of the patients, for the counseling, of the parents, as much as we can. Number one. Number two, during fitting cochlear implant, the rate of stimulation, you should lower the rate of stimulation, okay, and not to give the full amplitude or the full loudness for the patient. Regular follow-up. The clue is regular follow-up.
Yeah, Professor Dalia, probably the most difficult category. Children with ANSD, mild, moderate, moderately severe degree of, or even normal thresholds, but low effectiveness of hearing aids. First of all, yes, which are the most important outcomes measurements of amplification in this group? Should we orient only in aided thresholds or not?
Of course, you cannot depend on aided thresholds because sometimes you can do the aided thresholds and it's within the long-term average speech spectrum, 15, 20, excellent, very good. And the doctors say, oh, very good, go. But no language development. You'll try as an audiologist, audiologist, you try to make speech perception testing to see he cannot pronounce. So does he understand what you hear? So you can use picture format of speech perception and to see if there is a response. Okay, if there is no response, why you are waiting? You are losing the child. You are losing the things. Actually, for me, for the auditory neuropathy, when I decide to do cochlear implantation, it's the last resort, and I take it after long way of trying to get as much as I can with the hearing aid, because as you know, in some of the neuropathy, even after cochlear implant, you cannot predict. It's a highly individualized process. It's beneficial, but in some children or in some persons, it doesn't improve, and it's the same case as hearing aid.
Do you think that indications for CI are different in children with ANSD comparing with sensorineural hearing loss?
The indications, the indications is not different. The outcome, you look for the outcome. If you have a non-neuropathic, normal sensorineural hearing loss, profound, even severe, you know that this child will get proper amplification while implanted. You don't have any problem for that, and even no other syndromic features and etc. But in the neuropathic, it's another category. You cannot, as your first question, how we can differentiate pre versus post-synaptic in a child. Number one. Number two, I'm dead sure, and it's by research, it's a highly individualized process. You cannot guarantee that this child will be, of course, the cochlear implant improve, but in some patients, you may be worst scenario that it does not improve. So what you did, what you will do, okay?
So let's talk about single-sided ANSD with normal hearing on the contralateral ear. What do you recommend in these cases?
Actually, is a challenging case. Single-sided neuropathy is a challenging case. First of all, you should be quite sure that it's a pure neuropathy. You don't have any CPA problem, cerebropontine angle problem, any vascular lesion, any hidden thing that you cannot guarantee. Unilateral with poor speech discrimination, out of proportion with the pure tone, and etc. You should be very, very, very confident that it's a pure neuropathy, because it's not the case. Maybe it's starting and the other ear will follow, so it's good. But if it's alone, I have patients like that. I usually amplify, going to hearing aids, because the other side is normal. So I'm not going to leave this ear, never to leave this ear. I need to maintain the neuronal pathway, avoid auditory deprivation of such ear. So you should amplify as soon as possible. You are that sure that the diagnosis is pure neuropathy, so you can make amplification, following up and seeing what's going. Some patients will improve their speech understanding while amplified, actually, because maybe you increase the loudness of the sound, you are stimulating the nerve. Some will deteriorate, and the other ears start to appear, to be involved.
You amplify them soon after diagnostics, even in infant age, right?
Yeah, for sure. The binaural pathway, it's very important for children, for language development, for scholastic achievement, for communication, and avoid deprivation of such ear. You are deprivating the ear and making lesion in the brain, the auditory brainstem, the auditory pathway, the central auditory pathway.
So I would say that single-sided ANSD could be a bit challenging because child is passing OAE in maternity ward. He's hearing, he's developing, and diagnosis of single-sided ANSD sometimes we have quite late, in 5H, in 6H, due to this present OAE on both sides in infancy.
Yes, and there is a delay in the diagnosis till the age of 5 or 6 years, which is not bad, because at that time you can get behavioral threshold from the child, so you can know the exact thresholds. You can see low frequency affection, high frequency, mid frequency, a bit flat. So it's not a delay. The other ear is working well. Yeah. I say to the parents, there is hearing loss, but fortunately some children are born or get viral infection and lose the whole ear. But your child has a remnants of hearing that you are going to use, that you are going to make the binaural processing in a quite good way.
ANSD on the one ear and sensorineural hearing loss on the contralateral ear. Both are profound. Which ear is to be implanted first, or both simultaneously?
Actually, it's I didn't face I didn't face such situation till now. And if you are going to ask me by my experience what to do in such a child, in Egypt, binaural or bilateral cochlear implantation, it cannot be done on the insurance level. It's unilateral, and the other ear the parents will afford. So if I'm in my country, in the situation, I have to choose one ear. Which ear to choose? I will choose that with severe to profound, because I know that the consequences will be good, provided that normal radiology, no other abnormalities, and doing the preoperative assessment, electrical assessment. MRI is okay, the nerve is okay, the present, no problem. So I'll go quickly to fit and to make cochlear implantation in the severe to profound sensorineural. And the other one, the neuropathic ear, if there is possibility to implant it, I implant. But actually, it's very interesting to know what will be the response. One ear is in neuropathy in cochlear implant, and the other is sensory neuro. What will be the response?
Okay, dear Dalia, I know that in this November you will have a great event in your university. Yeah. Please tell us about it.
Yeah, in November. Now it's 2023 today. Yeah. This year, and this the anniversary of Ain Shams, the audiology unit at Ain Shams University. It's the 50 years anniversary, so it's our golden anniversary. We will have a great scientific event and of course social event, and we will be very happy and to receive you all, Gazet, and all your colleagues to share us this scientific event, which it's the collection of many years of work of my professors and of my colleagues, and we are continuing on the track, and we need to continue distributing our knowledge and distributing our experience across all regions, Arab countries and Middle East. So we are delighted to receive you. It will be held in Cairo, and there will be social and touristic program accompanying such event. And of course, the scientific, it's a very powerful scientific program, inshallah. And soon, when it's the scientific program is settled down, we'll get you back with any news, inshallah.
Thank you, Dalia, for this interesting interview. I'm absolutely sure that it will be useful for our colleagues all around the world. Thank you and see you again.